to speak, you press that. Good afternoon. We're back online, and thank you everyone for being back. Probably this is the Adults and Health Committee um, of the Council that's been meeting through the morning, and we meet this afternoon undertaking our health scrutiny tasks. A reminder, if you weren't present in the morning, that people are very welcome to film and photograph and to use social media as long as it doesn't disrupt the meeting in any way. But I do ask everyone to turn their mobile phones to silent or vibrate. We are being live streamed, and a recording of the meeting will be available on the County Council's website. There isn't a fire alarm test scheduled for today. If the alarm sounds, I'll immediately adjourn the meeting. We leave via these side doors to my left, where there is a fire escape next to the kitchen. We'll use that and assemble in the car park. I would like to welcome our cooperative members, councillors Organ and Dr. Nawaz. Um, uh, from East Cambs and Fenland, respectively. Councillor Garvey, Corinne Garvey, will continue to represent South Cambridgeshire District Council. And we've got two new cooperative members. Councillor Cameron Holloway is not in the room with us yet. He will be representing Cambridge City Council, and Claire Tivlin, who I'm hoping might be online. I'm looking up, I'm not seeing her yet, but she is online, so we can't actually see you at the moment, Claire, but you are very welcome. And when you wish to, will I see a hand go up? How will I see Claire? if you raise your hand, it will come up, Claire, if you're hearing us, which I hope you are. And Claire is representing Huntingdonshire District Council. And thanks so much to our cooperative members and this work being undertaken jointly between the city, district councils and us as a county council is really a welcome element of what we do. Now, sorry, I'm seeing Councillor Daunton on a
Chair, might I
process.
just ask a question? I wasn't quite clear. Councillor Tevlin's joining online. Is Councillor Nawaz joining online? I think Councillor Garvey is here in the room. Is Councillor Nawaz joining online?
We've got apologies, which I'll now read out. Thank you for prompting me, from Councillor Dr. Nawaz. He was also due to join us earlier this week and wasn't able to be there, so I guess he's not very well. But also Tom Sanderson, who was with us this morning, has had to leave. So we have apologies from Councillor Sanderson and Nawaz. Thank you for drawing that to my attention, Councillor Daunton. Now, two substantive items of health scrutiny that we're dealing with this afternoon. Firstly, item 11, maternity services at Cambridge University Hospitals NHS Foundation Trust. I'm very pleased to welcome Roland Sinker, CBE, the Trust Chief Executive, who I meet with regularly, and Dr. Canwell Moore, the Trust Divisional Director for Women's and Children's Services. Please do come forward to the table in front of you, please. And we're also pleased to be joined by Caroline Tyrrell-Jones, the Communities Programme Manager at Healthwatch Cambridgeshire. Healthwatch plays a vital role in championing the voice of service users. They have a standing invitation to attend all our health scrutiny meetings, and can I advise Caroline to join the table as well. We have also, as we typically do, invited the Children's Young People's Committee spokespersons to join us for this item. And Councillor Bryony Goodliffe, who in fact has been with us this morning, is also present. I'm not sure at the moment any of the other spokes from that committee are here. If any of them do arrive online, Rashenda, please do alert me when they do so. I'd also like to say I'm particularly pleased that last week Councillors Black, Tevlin, Murphy and myself visited the Rosie Hospital at the Trust's invitation to meet senior clinicians, leaders and service users. We really welcome the opportunity to see the service in action in preparation for today's session. We were given a warm welcome, but also I would particularly like to record that we've not done a visit in advance of scrutiny before, so we were testing it out. And I have to say, I thought it was an outstanding success. They gave us a lot of time, but I felt that you and your colleagues really appreciated the attention we were given, but also we were able to have a really open and respectful and non-defensive discussion about the issues, which I am sure is going to inform a higher quality of debate. We have a high quality debate, I hope anyway, but I think we'll further improve the quality of our debate in the scrutiny session. So I'd like to thank the representatives of the Trust very warmly for offering us this opportunity, but I'd also like to thank Councillors Black, Tevlin and Murphy for giving their time, and I thought it was a really excellent addition to how we undertake this work. This scrutiny section was prompted by the Care Quality Commission's report into maternity services at CUH in May 2023 as part of a national inspection programme. At that time, the hospital was rated as good overall, but with maternity services rated as requires improvement. We felt it was right to allow the Trust some time to discuss the issues, address the issues raised by the CQC, rather than us just jump on a bandwagon at the time. But we feel this is a good opportunity for us to look back in terms of the questions that were put to them before, but also to hear progress in responding to them since. I would say we meet Roland regularly as part of the quarterly liaison work that we do in this committee in preparation for health scrutiny. I've met Roland many times in that context. I commend the relationship that we already have with him, and I invite him to start the presentation before we move to questions. Roland.
Great. Thank you very much for having Kanwal and I here with you today. And I would just like to start by echoing your comments around the strength of the visit that we were able to do together. I thought it was great learning for us in the hospital, and I felt we were able, in sort of slower time, able to talk through some of the issues that we're facing. So perhaps if I could just start by saying it's the first time I've come to visit you face to face in your new accommodation. And I remember coming for the first time to see you in 2015-16, when Cambridge University Hospitals was rated inadequate by the Care Quality Commission with a very significant financial deficit. And I spent a good deal of time coming back and forth for what I felt at that stage were really good, constructive challenges from you as a community as to how the hospital was faring and how it could do better. And I think over the years, as you've said, I think together we've always identified the areas of strength, many of which you have been huge supporters of, but also when we've had real challenges and difficulties. Over the years, urgent and emergency care, the data breach of this time last year, we've always tried to be as transparent as we possibly can be and take help and support where we can. In opening remarks, in terms of areas of concern for the hospital and our population at the moment, there are lots of things we could talk about, but the two areas that are occupying the board and our Council of Governors at the moment are urgent and emergency care and maternity. And it's right that we should be here today to talk about maternity. But what I would do on to say about maternity is to situate it, that it is not of the scale of challenge that we faced in many areas in 2015-16. And within maternity, there are some areas of concern, safeguarding training being one where we've made enormous progress, Kanwal, that we'll talk about in a moment. But at the heart of this, it's about numbers of members of staff and their ability to provide the service that we need to, and how that group of staff work together to provide the very best care that we can. Those are the two main areas of focus for the board and our conversations with our patients and our population. But there are clearly other areas that we'd be very happy to explore and talk about: how service users are able to shape our services, how we've taken additional support and assistance to help us move forward. That was all I was proposing to say by way of introduction. But Kanwal, is there anything you would add at this stage?
I welcome the opportunity for us to discuss the improvements and changes we've made at the Rosie Hospital in response to the CQC report from September last year after the visit in May. We have made some significant improvements and changes. However, there are areas that we are still focusing on very deeply and will institute further changes, but I'll go into those in more detail. It depends how you'd like me to do it. There were the 13 actions that came out of the CQC. One must do and 12 should do's, and they've been split into several work streams. So I can take it forward depending on which way you'd like.
I think the questions will afford you that opportunity. Can we call you Kanwal, by the way? Is that okay? I know Roland doesn't mind because I've done it many times. And also, just next time you speak, can you move the machine closer to your mouth? I will, at this point, though, also welcome, can I call you Caroline? Is that all right? Yeah, Caroline Tyrrell-Jones from Healthwatch, and I'll invite you just to say a few introductory remarks, maybe.
Thank you for the opportunity to come along. Yes, we don't have a great deal to add in relation to what is discussed on the paper. Obviously, from a Healthwatch perspective, it's our job really to speak about the public voice and how the members of the public, patients, service users experience the services. We tend to work quite closely alongside the Rosie Maternity and Neonatal Voices Partnership. So we tend to channel really most of the feedback we hear through them, because it's very, very important they exist and that they're supported to do that vital piece of work, being close close to the hospital. And I have to say, I find that they have a very, very productive relationship with the trust themselves, which is good to see. I know there's a lot of ongoing work to try and encourage people of a more diverse mixture of backgrounds to join in with that, but that's a battle that we all face all of the time. So yes, we're glad to see of the good relationship that the trust have with groups similar to that one.
Thank you. And if you wish to speak later in the debate, just put your hand up like anyone else, and I would welcome that. So we now go into the questions, and I am delighted that Councillor Goodliffe is here today, the chair of the Children's and Young People's Committee. I invite her to make the first question.
Thank you. And I'm cheating. I've got 3. Sorry, Chair. First of all, looking at 2.2 and the vacancy rates, obviously we can see that there has been progress made, but can you give us an idea of how these current vacancy rates compare to, we use the phrase statistical neighbours, I'm not quite sure what the equivalent is, equivalent hospitals or others, but also national sort of vacancy rates and what you're doing to address those. Secondly, in the Appendix 1, it states that 90% of patients are seen within 4 hours by a doctor, which indicates that 1 in 10 aren't. But the initial triage data only has the first 15 minutes data. So my query is, are we seeing all of those patients by a clinician, not necessarily a doctor, within an hour or 4 hours? Do we have that comparable data? And then, Roland, I'm really pleased that you mentioned challenge, because I do have a query and a challenge for possibly the entire trust. You state in the report that safeguarding training is compliant with trust targets of 90%. NHS England Safeguarding Accountability Assurance Framework, 4th edition, 2024, and Working Together to Safeguard Children in 2023, it states that providers must assure themselves, regulators and commissioners that safeguarding arrangements are robust and working, including effective training of all staff. The document itself goes on. With my safeguarding hat on, looking particularly at children, but obviously very vulnerable women in this position, I'd say that 90% is not applicable for this type of training. And actually, as a trust, it should be taken out of that 90% level of compliance and look far, far higher, if not towards the 100% compliance, and that safeguarding needs to have a different view across the trust. Thank you.
Thank you. I hope it doesn't bounce Councillor Horgan too soon, but in the preparation, you also indicated a question in this round about causes. And just to give notice to Councillor Hay, I will then go to her. Councillor Horgan.
Yes, thank you, Chair. I appreciate there is an action plan in place, but I found it difficult to actually identify the specific problems that you were trying to fix. I think you can read between the lines of inadequate staffing levels, inadequate training, inadequate supervision of staff and their actions. Were there other underlying causes that created the situation that caused the CQC to be concerned? Oh, and the other thing was, thank you for updating Appendix 2, I think it was, with the missing months, but I see that there is at least 1 month still missing from that chart as well. So again, just makes me a little worry about who's checking things before they're sent out.
Okay, thank you. Councillor Hay, please.
Thank you, Chair. I'd like to know what lied behind the CQC finding that staff felt respected but not always supported and valued. I mean, is there a cultural issue, and has it been addressed? Has it been tackled? But also, I understand that full staffing wasn't always available. There wasn't full staffing. has that been totally resolved now, or is recruitment still ongoing?
And the last one this round, on behalf of Councillor van der Ven, who's put these questions in writing as she's not able to be here. She notes the 2 red flag events that you noted in 2022-23, where a midwife wasn't able to give continuous one-to-one care. How often does that happen? And what is the difference between what you're hoping to do and what patients might expect you to do, and what is the reality? I'll just give notice to Councillor Murphy. I'm just looking at her. If I can make her first in the next round, will that work? Yes, it will. Okay, so I just ask Canwell and Roland to come back.
Chair, thank you very much, and thanks for the questions. Would you like me to answer them in the order that they came, or it might be more helpful if I start
as you choose?
Okay, so perhaps if we start with the question around what's really going on here, what are the underlying causes, and then we can get into the detail. Is that acceptable? Great. So, I mean, Canwell, you'll obviously have a view as well. I think, as I said in my introductory remarks, I think at the heart of this, there are 2 material issues and then a series of subsidiary issues. And I would say that all that the CQC found, we told the CQC before they came in. So this wasn't a revelation to the organisation. I think the speed of our response and energy that we were bringing to resolving it would be something we would definitely reflect on. So we knew what was going on. We told the CQC, they said, yep, when they came in. So the 2 core issues here relate to the numbers of members of staff, the numbers of midwives and the numbers of doctors, which then leads you into the issues around triage. Do you have enough human beings to be able to provide the triage and follow the process? We were doing it, but it was ad hoc. So that's issue number 1. And then issue number 2 is the culture question of, are people working well together in a team, which is difficult to do if you feel you're understaffed and enormous amounts of pressure. So if you want to know what's driving all of this, it's that bundle. That then leads you to a set of subsidiary issues, which are enormously important around things like training, safeguarding training, and levels of engagement with patient groups, where we were still very, very strong. But Canwell, in terms of the underlying position, is that a fair summary?
I think that's a fair summary of where we are. That the 2 issues were previously around workforce and culture. Would you like me to? Yep. Okay. So when I look at the workforce in relation to surrounding trusts, and we are in a similar position to other trusts that have similar acuity to us. We find that trusts with lower acuity tend to have better staffing models or establishments and fill rates on the establishments, but that is often thought to be related to the acuity and difficulty of the work and the ability to attract staff members in. In terms of the midwifery position, we've consistently improved this over the last 5 years. As we came through COVID, it was very difficult. We had a high rate of vacancy. So we did targeted recruitment, both through local UK trained graduates and then also overseas recruitment. In addition to this, we do have a training programme within the Rosie, and we offer all our student midwives posts at the end of it if they have passed, because they are deemed appropriate for work. The position we are at currently is that we are very slightly below establishment at about 7%. We aim for 5%. However, this month, in fact, this week, we are in the process of we have our new starters from the student population, and this will in fact take us over establishment. This has been agreed at executive level to allow us to maintain our establishment at as near to 100% as possible for midwifery, and to allow for turnover, sickness and maternity leave. We do note that in maternity, we tend to have a higher level of maternity leave than in other areas of the trust. In addition, for midwifery staffing in particular, and this relates back to training, the training issue is that midwifery in the midwives need approximate over 50 hours of training per year, and that we have now changed the way we deliver that to be in week blocks. We've had to change the staffing model to enable us to support that, so that the midwives do not get pulled away from their training to fill gaps in the rotas, and we are becoming successful in that, and that is shown in the training work stream within the action plan, that we are on trajectory to complete all the training and meet our maternity incentive scheme targets for that as well. With regards to the medical staffing, we were, prior to COVID, at a business as usual establishment and fill rate, which was acceptable. We've had the normal turnover within that. However, as part of the process from the CQC report saying that staffing should be looked at, we have reviewed our staffing model and the actual establishment. So we have increased the establishment baseline. So the first tranche, so we've gone through the investment committee and are in the recruitment process for the first tranche, which was 6 junior doctors and 6 consultants. We have now recruited all the junior doctors. Actually, I should be calling them residents now, so apologies. We have recruited all the residents. They have not all started in post yet. That will happen within the next month, and that will have an impact and change on the rotas and fill rates for things for areas such as triage. With regards to the consultants, we have done 2 rounds of recruitment so far, but have been unsuccessful in getting all the posts filled because there weren't the appropriate candidates. So the way we have approached this now is to do targeted recruitment and look at when trainees will be completing their training. We have a set of interviews coming up very soon, so we're anticipating and hoping that we will be filling the remaining posts within the next 3 to 4 months.
Should we just, thank you, Kanwal. Should we just pause? I think we've maybe answered 2 of the questions that were in a number of the comments made. One of them was, what's really going on here? And then the other was, where do you sit in terms of staffing and culture? And maybe take any comments or reflections back on those before we move on to the issues raised around triage, safeguarding training, and the red flag events and the missing data.
Okay, I think that's a very fair suggestion. I did have a number of members who also wanted to ask questions about workforce. So at this point, I'll ask first Councillor Murphy, but then also Councillors Seif, Slatter and Daunton if they want to follow up, and then we'll come back to you. Councillor Murphy first, please.
Thank you. I really valued the session last week because it really helped bring a lot of things to life, and to see the interrelation between the sort of plan and the reality. That's essentially what we're trying to get at. So it was very helpful to me. But I suppose my question is really that I didn't raise at the time is really there's a lot of data that you're collecting that you're going to go on to talk about, and there's a lot of ways of working that you're trying to establish. What I want to know is how effective you think you are being at getting that positive feedback going, of sharing the data, understanding where the figures are showing going in the wrong direction, for example, or the right direction, and understanding then what is behind the changes in practice that have led to that. So there's a kind of feedback loop between the data and the practice. I just wonder if you've got a comment about that. It's sort of workforce, it's sort of data.
So we're going to stick to workforce questions. The other 3 councillors, if you feel your question's been answered, don't feel that you have to, but I'm going to give you the opportunity. First, Councillor Seif.
Yes, thank you. It's related to everything we've talked about up until now, but it concerns the satisfaction scores of family and friends. I just wonder what it actually means, and what, obviously there's a lot of data behind it about what constitutes satisfaction in maternity services. There's obviously dissatisfaction if things don't work out well medically, But that may be something that can't be avoided at all, other than in the general care that surrounds that. I mean, a woman may be in labour for 48 hours, she's going to be extremely unhappy, but that is a natural process for the most part. And then, of course, the care around the mother in particular, and actually parents generally, after the child is born, and particularly with newborn first-time mothers who are new to the game, and they're very nervous about everything and need a lot of attention. And now that may be a function of staffing, but it may be a function of perhaps training as well. So I just wonder if you can break down for me the satisfaction, what is comprised in those satisfaction scores. Obviously, there's one score I think is much higher than another. In other months, it's very little dissatisfaction. But it seems to me that we need a little bit more information about what has constituted those scores. Thank you.
Fair question, but can people be a bit disciplined sticking to workforce in this round? There will be further opportunities to come back. The question's put now, so I'm sure it was heard. Does Councillor Slatter want to come in?
Just a small thing about workforce which hasn't been mentioned yet, and that is interpretation services. I'm very aware, I'm the county councillor for Trumpington. I realise not all your patients come from Trumpington, but certainly Trumpington is fairly typical of quite a lot of Greater Cambridge in having a lot of people whose first language is not English, and at a time like childbirth, this can be absolutely critical. I mean, there have been some horrific stories, of course, and that tip of that iceberg suggests that there are problems for communication, and particularly for women if they've come with partners whose job has brought them to this country. Are you struggling to make, to actually be able to understand and be understood in terms of language?
And lastly, Councillor Daunton.
Staying with a similar theme, actually, in terms of recruitment, you mentioned overseas recruitment. And what additional measures do you have when you bring in staff from overseas to help them bed in, to help them to find accommodation and to acclimatise to working in a new country? That's my main question. And my second question, which is quickly escaping me, come back. I'll come back later.
And I'm going to slip one in on recruitment for myself. It was very interesting what you told us last week. It's a third international, a third local, and then a third people from elsewhere in the country. And that certainly gave me an insight. And one of the things that you said that, notwithstanding what you've said about training that you do directly, you are dependent on the number of people that go to medical school, and fewer people go away to medical school and then live in Cambridgeshire and come back and therefore apply for your jobs. So what could you say that we should be pressing for in terms of money, numbers of midwifery training, beyond what you can do directly yourselves and the numbers going into medical school? I'd like you to answer that question. Again, the order you choose is fine.
Good, thank you.
Councillor
Daunton has recalled her question, and so I will invite her. Thank you for being interrupted.
Thanks very much. So we talked about recruitment. Could you say a little bit about retention? Once you've recruited people, do they stay? Thanks.
Thank you. Roland.
Great, thank you. So if we get lost in the questions and forget something, it's not because we're trying to avoid them, it's just that we'll have missed them. Can I suggest we stay in the last round of 5 questions and then we go back to the originals, but we'll do the 5 and then come back. So Carol, shall I talk about support for overseas colleagues who are joining us, other things we might do to support people staying in the area, which I think was the question, Chair. shall I pick up interpretation services? What do you want? You'll do interpretation services. I'll do family and friends, and you do data and culture. I hope you don't mind us working this through. Okay. So first of all, you're right. A very large percentage of our colleagues who join us in our 13 to 16,000 members of staff at Addenbrooke's and the Rosie, our colleagues who are joining us from overseas, and we do an enormous amount to welcome them into the hospital, provide accommodation for them until they find permanent accommodation after they've been with us, and to try and celebrate and make them feel involved in the organisation. Do we get this absolutely 100% right? I don't think so. I think we do a lot of things at the outset and while they're here, but we don't yet, I think, have the right mechanisms to really get our teams well and truly integrated over a much longer time period. I worked at King's College Hospital in South London for 8-9 years before I came here 9 years ago. And I think just by virtue of there being a much more mixed, diverse workforce there for a longer period of time, there were things that were better embedded there that we're looking to learn from. So I'm saying solid, but could do more, but it's well intentioned. Secondly, I think the question you were asking, is there more that we could collectively do to make it easier to stay in Cambridge or to come and work at CUH and then stay? And I think there's a lot of work that we need to do around affordable housing for key workers, transport, access to schools. And in due course, we are going to have to really, I think, lock into the conversation around what I would call the London waiting or the cost of living supplement for our staff. I mean, it doesn't bear much scrutiny that you can go quite a short distance south and get paid quite a lot more. And yet Cambridge, we know, is as expensive as many parts of London. On recruitment and retention, it's a hugely important question. That the strongest correlation we have around retention is when we're well recruited. And the charts are quite startling, is when you're fully staffed and people are working in teams looking after a particular group of patients, they will tend to stay if you can get some of the hygiene sorted around housing and transport. So it's a very important question for us. If I stop having done those three questions, and then Kanwal, do you want to pick up on interpretation and data and culture, and then I'll come back to family and friends.
So interpretation was raised by the CQC as one of the areas that they wanted to see some different approaches on. We have done quite a lot of work around this and looked at face-to-face interpretation for booked appointments. So where possible, with a language that is accessible, we will have face-to-face interpretation. We also have access to Language Line both by phone and by video, so using an iPad, and this is also used out in the community as necessary. The feedback on this from both the service users and the midwifery teams has been very positive, that this has been helpful in improving communication. So we have the planned communication within the planned appointments, but also in the more emergency appointments or the acute care phases, or when they're away from the hospital as well. So an example of that was an Arabic interpreter on an iPad was used, and this was dialed up within approximately within a very short period of time. So that was able to manage a quite difficult consultation at short notice in fetal medicine. It's a reliable and easy service to use. I've used it myself. And you can pre-book it as well. The only area of difficulty on occasion is with difficult to access dialects, and we do find this occasionally with groups such as the refugee groups, that there will be a patient or service user who has a dialect that we struggle to get an interpreter for, but we would then use an adjacent language for that as well. So the feedback, and since this has been put in place, and it is in line with the rest of the trust as well, is that this has been very positive and is giving the results that we were hoping for. With regards to the data, there is a lot of data collected, and that is partly from our regulators asking for it, and through the many numbers of reports that have generated action plans and KPIs over the years. So we have over 200 audits a year that we have to carry out to demonstrate that we have safe practice. These are fed back through a variety of techniques, including the Rosie report, huddles, and also directly to staff. What I will say, though, is that the staff currently do feel somewhat demoralised by the level of data we're having to collect, and we are in the process of trying to rationalise this and make it more manageable for them to collect and use the data as well. Part of the process of using the Maternity Improvement Oversight Board, we use that to disseminate information as well.
Thanks very much, Canwell. So just on the last of this round of questions, and then perhaps, Chair, we could go back into the others so we don't get lost. On the family and friends and family test, so we look to find as many different indicators as we can, noting Canwell's point around sort of data overload, to have a good back and forth debate with patients. And we heard a good example of that through Health Watch at the beginning of the session. The complaints are an incredibly powerful set of feedback for us. The sort of feedback we get through the Freedom to Speak Up Guardian in the organisation from frontline members of staff is another point of triangulation. And at the heart of it, the friends and family test is exploring exactly what you're looking at, which is not just, was the clinical care good? It's how did it feel? Did we get this right? In terms of the much broader range of things that we want to consider about an episode of care. So it's trying to be as comprehensive as possible, not sort of what were the medical treatments like. Okay. Sorry.
Can I just explore that a little bit further? I mean, specifically, what sort of problems do you encounter, and what are you doing about it? Perhaps more importantly.
I mean, Canwell, do you want to talk about the sort of feedback we get from patients that we need to lean into more, the problems?
I think you alluded to something very important earlier when you talked about medical outcomes versus satisfaction outcomes. And our data shows that our medical outcomes are good. And it's very easy as a clinician to really focus on that and say, yes, but we're getting good medical outcomes. It's very important, ultimately the most important, but that isn't the service user's journey. So it's really important that we engage with, as you said, what should be a physiological process and part of the natural progression in someone's life, to make that an enjoyable and occasion that when they look back, they go, this was a good thing that happened. Part of that work is the work we do with the RNMVP, that they give us that feedback in telling us, this is the area that
Do you mind just
work.
explaining that acronym?
Yeah, sorry. The Rosie Maternity Neonatal Voices Partnership, which Caroline was talking about earlier. So that's our patient service user group. We work very, very closely with them. And the chair spends a lot of time working with our senior management team, is involved at interview level. So it's a valuable resource that we couldn't work without. But when I think about what are the areas that they comment on, it's the care coming into the actual time of labour and what happens in the postnatal period. I think our focus now is really on that postnatal period and how can we make that a more pleasant experience for our patients. So I can't say to you that it is as good as it should be at this moment, but areas on our agenda.
If I could just build on that, if you were to go back 2 years at Addenbrooke's and the Rosie, our quality committee was very focused on the big backlog we had on complaints responses and sepsis. So effectively one of a very serious infection that we deal with. And on the complaints piece, the strongest sort of set of interventions was to intervene early and just have a conversation with people about relatively small things that hadn't gone quite right at the time. And we'd ended up putting them into an enormous sort of parking lot of complaints that needed a really formal response, as opposed to let's have a quick and early dialogue about the way that our colleagues were communicating with patients, appointment cancellation and rebooking, or small things in a ward or an outpatient area. So what I'm saying there is it's often those sorts of things that we're looking into at a trust level. Chair, should we go back to the first set of questions? And Camille, do you want to pick up on the triage piece, and then maybe I can pick up on training, and then we'll come to the red flag event and the missing month of data that you raised. Is that okay? Do you want to start on triage?
So triage, which was an area that was raised within the CQC report, is effectively the emergency front door for the obstetric department. And when a patient attends, the first thing we do, and a midwife will see them immediately, or we take phone calls in the first instance. We have approximately 2,000 phone calls a month, which then convert to around 1,000 visits to the triage area. The majority of those visits, 75% of them, are within daytime hours, so between sort of 8 and 6. Once that patient has had a discussion, they will be put into one of several tranches. So must be seen immediately, which is immediately within 15 minutes, within an hour, or within 4 hours. And those are the measures that we look at. They are split by should they be seen by a midwife or an obstetrician. And that was an area that the CQC said, can we do better at? We put in a number of measures in place in the staffing model that we had for the midwifery side, which has improved our figures for the 15 minutes immeasurably. So we are now within KPI for that. With the medical side, this is the area that we are still working hard on and keeping under close review. And that is why we've started putting in the extra staff. We have not reached the level we want to reach yet. So in mitigation for that, we are always checking what is the harm, what is coming out of this if we do not see that patient in time. And when we say we didn't see that patient within 15 minutes, did we see them within half an hour? Did we see them within an hour? Or was it 3 hours later? And actually, I can say that we see 40% of those remaining patients within a further 15 minutes and another 40% within another half an hour. All those delayed patients have been harm reviewed. So for instance, we've looked at the whole of August and there was no incident of harm. And in fact, what it has demonstrated to us is actually we're possibly overcautious in how we classify the patients in the first place. But this is work that we are continuing. We are deep diving on it, and it is a very important area that we focus on. Part of having the extra June resident doctors, that's part of the work that will go towards this, and we should be seeing a difference in our next round of figures for October because we've now got that. We're now filled to establishment, but we will not see a full difference or as much as we'd like until we have the extra consultants in place. Part of that will cover those daytime hours because that is where we're focused. And then the next step will be, what do we do for nights and weekends as well? I hope that answers the questions around triage.
Great. Thanks very much, Canwell. Just on the other questions, and Canwell, you'll correct me if I'm wrong on these. So first of all, just on the data, I was just checking in the appendix 1 of the report that I think we submitted. We think we've got the friends and family test data. We think it's all there. So if we're looking at a different report, it would just be helpful to have flagged where we've got the missing data. So sorry.
Just for the public listening online, Jeff, do you mind saying that with the microphone on?
Sorry, yeah, just to point out, April 23, I think, is missing.
So you're right. So you're saying January, February, March, and then you're right. There is April and May. I think that may be an omission in the table. If it's okay, we'll come back to you on that data.
Yes,
that
it is.
was sent through again as a further amendment to Richenda. So.
Okay, Richenda is indicating, so don't send it to us again. We'll just make sure that's circulated to members or recirculated. Councillor Horgan?
Yeah, I'm actually referring to the recent report, which still has December 2023 missing. So that's 2 attempts now of sending us a simple list of scores and there are still gaps in it. And this comes back to that oversight and supervision concern that I personally have, because the information's coming out in your name, Mr. Sinker. And I'm afraid it doesn't fill me with a lot of confidence that after 2 attempts, there are still gaps in the data. Even when you fill those gaps, I'm looking at 2024 data versus 2023. And the way I read it, the scores are getting worse and not better. But I wanted to have a full picture to make sure that I could see everything.
Let's divide that up. Do we feel December 2023 is missing? I'm looking at both Rashenda and Roland. Roland?
We're just looking at the additional submission, and you're absolutely right. We apologise for that. There's no December data in the resubmitted table.
Let's not
apologise.
Hit you with birch twigs about that. You've acknowledged it. If you do send that information to Rashenda will make sure it's distributed. So on the wider point from Councillor Horgan, which is not just have you sent this month or not, but on is it getting worse rather than better? Give you a chance to reply to that, please.
Yes. So first of all, we apologise for the failure to submit the data on 2 occasions, and we'll go back and look at why that happened and find a way to submit it as appropriate. So we've got the full picture. Looking at the data across this period, the numbers do exactly what you say. They deteriorate over that period. We would need to come back to you with further details as to anything we think is driving that beyond, if you like, the running of the service. So I don't have an immediate answer for that now, Canwell, unless you do.
I don't at this moment.
Okay.
Everything answered from the first round, just double checking that.
So I think we've still got 2 to pick up. So one of them was the reference to the red flag events. That's right. And Canwell, do you want to pick those up? I think what we were saying here is that the outcomes for the service remain very strong. And I think in the case of the red flag event or events, there was 1 case of labour, wasn't there, out of a large number. Do you want to talk to that?
We have between 500 and 550 births per month. And we've had this 1 red flag event of not having one-to-one care in actual labour. We have put in additional staff at a supernumerary level to manage the flow of patients and staffing across the unit to identify when there may be areas that are difficult. And since that event, we've not had any further red flag events in case of one-to-one. This includes times when we would otherwise have gone on potentially on divert. We constantly monitor, are we in a safe position and can we give that care that we need to? And if we can't, do we need to look at asking other hospitals to support us in the same way that we will support other hospitals when they are in that position as well? Thank you.
Thanks, Canwell. And then I think the last unanswered question related to safeguarding training. And you can see in the report the levels that we're at, and you can see the very low levels that we were at when we introduced the training for level 3 safeguarding in 2023, and how we've gone up to much higher numbers and are doing well. I think your larger question around the rigor and depth of safeguarding training is something we are looking at again for the reasons that you talk about, which is my way of saying we're not sure that the targets are set at the right level. I would say a lot of our training deteriorated quite significantly during the COVID period, as did staffing. And some of the issue we faced is getting all of our training back up to speed. And we've had to not just throw more training at a limited number of staff, we've had to find new ways of providing that. So I think it's a very helpful challenge and something we'd be happy to come back to you on when we've resolved it. Thank you.
Okay, thank you. I'll give notice to the members who want to come back a second time. You will get that chance. But at this point, I want to ask members who've not yet spoken, but who may wish to ask a question. I'm just going to give those members a chance, including to Councillor Devon online if she wants to speak, and anyone in the room who's not yet indicated. I'm looking around before I bring members back who've already spoken. I'm not seeing any arms. Is Councillor Devlin still with us?
Hello. Yes, I am. I don't have anything to comment.
Okay, thank you we heard your voice very clearly there, so that's great. And thank you for being with us. I'm just giving a moment. Okay, we had a number of other questions indicated from councillors who have already spoken. Can I just check, Councillor Seif, have you asked all your questions that you wanted to? If not, this is your next chance.
Thank you for giving me that opportunity, because I was actually going to relate my first question to something that Dr. Noor drew attention to, which is the possible difficulties, the difficulties you seem to be experiencing at particular times. The wonderful thing about maternity services is that they occur at any time of the day and night. They are no respecter of weekends or Christmas Day or everything else. And you intimated before that that may be a pinch point in terms of recruitment and adequately staffing up the department. And I just wondered, it's partly related to the question about care, the aftercare of the patient, whether that is a particular problem, and again, how are you going about solving it? I mean, I certainly understand why those pinch points would arise.
I'm going to give a chance to the other members who took part in the preparation and had other questions. If you feel that you don't want to put it, don't feel that you have to. But the next one on my list is Councillor Slatter. Did you want to come back at all?
Different question.
Yeah,
happy
please.
to wait in line. And that's to do with bed spaces. I mean, we're very aware, and I know we've got a meeting coming up about the biomedical campus generally, and whether there's enough response to the growth in the population in the area, and the lack of provision automatically on the back of that. I'm wondering whether you feel that you have enough space for people to stay on, you've mentioned postnatal, for for some of the reasons that aren't really urgent, but sometimes the mother really needs a bit of a rest. And that might be a luxury you can't afford to give them. I think it's particularly when it's second or third births. Sometimes that extra 24 hours can make all the difference to their postnatal recovery. Just wondered whether you are basically short of space.
And I'm going to ask same additional opportunity to speak to councillors Daunton and Horgan. Councillor Daunton, did you want to come back at all?
I've got a question on partnership working, but maybe that's not for now. Maybe you're coming on to that.
No,
later.
this is for now.
Oh, it is, right, okay. The report, you've got a section on partnership working. I'm sorry, my screen's just decided to close itself down. You've talked about partnership working. I'll try to remember the question without looking at the precise words. And you're learning from the North West Anglia Trust, I understand. Can you just explain a little bit more what form that learning takes? They were rated good, weren't they? And so you're having regular meetings in a group of, is it 10 hospitals? Is it a structured learning? And if it is, just explain how that learning, how you take in that learning.
Councillor Horgan, did you want to come back?
Well, as we've not got any answers at the moment as to why this year's figures are worse than last year's figures, despite all the improvements that are being made, I'd probably just like to sort of adjust my question to just how difficult is it for a patient or a member of their family to complain? Because do they have to go through the PALS team, or how does the process work, please? Because I think basically if the only way they're able to express themselves is in the friends and family test, it might be that it's actually the complaints process which is the failure.
Please.
Good. So, Canwell, do you want to pick up what I heard as the question around staffing at different times of the day, and then should we both pick up on the bed capacity, and then we'll do the partnership as well together, and I'll come back to the complaints. Is that okay?
Yeah, cool. Thank you. With regarding to the staffing at different times of the day, it is surprising how you can actually predict quite well the ebb and flow of patients, even though they come on an emergency basis. So there is an understanding of what expectation of flow you would have through a unit. And so looking back through data allows us to say, we can see that, say, for triage, for instance, the majority of the patients would be coming in the afternoon. So even though triage, you can't predict when those patients are going to turn up, you can see over time that these are the times of the day, the times of the week, even the times of the year when you would expect more or less patients. So the staffing models are built around that. So with regard to the medical staffing model, that's part of where the first tranche came from, that we knew that we needed to put in extra staffing during that daytime period, and we are recruiting to have a further junior member of staff for nighttime. With the midwifery staffing, we have a tool called Birth Rate Plus, which looks at acuity and the need and the numbers. That was last used in August 2022, and we normally would carry out that process every 3 years, but we are currently renewing that process because of the discussions we've had within the Rosie about staff feeling under pressure. The previous Birth Rate Plus, we are established to that, and we don't have vacancies, as in we've filled our vacancies, but in spite of that, the feedback we've had from the staff is about that pressure. So we've listened to that and we've said, right, we need to look at this again and see what it tells us. So we are able to predict to a certain extent when, in fact, to a greater rather than a lesser extent, when we'd expect those patients to come.
To come in or to give birth. Sorry.
Yes.
To actually give birth.
Yes.
I mean, yeah, I guess what I had in mind and what I've seen, limited experience as a father and grandfather, is that women seem to give birth at the same time, and there's a bit of a panic, and those who are now nursing the newborn child are left whilst everybody goes and attends to the actual birth. That's not necessarily with your hospital. It may not, but
I understand what you're saying, and anecdotally, it often feels like that. However, because we have an antenatal area, the actual delivery areas, so both the Rosie Birth Centre and the delivery unit, and then we have a postnatal area, those patients are separated out.
And the staffing is as well.
And the staffing is appropriate to those areas. So once a patient is in labour, they should be receiving their one-to-one care.
Thank you very much.
Good, thank you. If we come on to the question about beds and capacity, I think a lot of the scrutiny that you're providing more generally to the hospital, general practice, community service and social care, I think is pushing us quite rightly towards what's the right conversation to have with the public and our patients around the model of care, and how much of that can be supported by technology, how much needs to be more people, how much of it needs to be more physical space, and where should that be? And I think that's exactly the right way to approach it. And then you get to what additional beds might you need on the hospital site. And I think we would all recognize that that model is not currently right. What we don't want to do at CUH or on the biomedical campus is just build a shed load more beds for more and more patients. What we want to do is to really work with other people around the model of care. And as we all know, investment in social care, community services and general practice is bluntly more important than investment in the hospital. And that is set out in the Darcy diagnostic of the NHS that was published 4 or 5 weeks ago. Even within that, though, we do need additional beds on the biomedical campus in a range of services. And where we've put those in place, we are able to see really improved outcomes and use of taxpayers' money. And the most recent example would be the Cambridge Movement Surgical Hub, which is basically where we do joint replacements. We've seen length of stay go from about 5 days to under 3. Much, much better for patients. And we're doing 60 or 70 joint replacements in there a week, which is terrific. I think maternity, it's a similar picture, but Canwell, do you want to talk about the detail on that in terms of what we have available for people to stay in for an extra 1 to 2 days?
So maternity beds are ring-fenced and they aren't used for other specialties. So in that respect, we are protected against the pressures that the rest of the hospital feels. Those beds in the antenatal, postnatal and the actual perinatal period are all protected. The number of births that we are seeing at the Rosie has remained the same, and if anything, we are seeing that it has gone down slightly. We may anticipate that that will increase as there is a population increase, but at this time it's going down little. What we have seen, and this is what would have an impact on potentially on how long patients would want to stay after they've given birth, is that the acuity has gone up. So we're seeing more C-sections rather than straightforward vaginal deliveries, and we're seeing more patients that need additional medical care and help. The impact of this is that the configuration to which the Rosie was built may not be absolutely correct now. So we have the right number of beds, but will they be in the right spaces is something we're looking at in a bit more detail. And it's the staffing support that is important for that. So one of the things we'll be looking at is an enhanced recovery program, which would give that extra support, and then also transitional care for those mothers that need help, for additional help with their babies. But this then comes back to the staffing again. So we do not discharge patients until they're ready to go, and that's quite important. And are they ready to go isn't just a question from a medical point of view, it's also a question of, is that mother confident to take home their child and look after them as well. So we do have enough space, but it can sometimes be tricky to manage it.
Thanks. If we come on to the question around learning, so there are two different areas, I think, here. So there's partnering with our local hospitals, North West Anglia Foundation Trust being the one that you've identified, and then the group of 10 hospitals are the 10 national big teaching centres who are very analogous to us. But we can learn from both of those communities very effectively, and we can also share learning from ourselves with them. But Kanwal, do you want to mention the sorts of examples of what either we've shared with others or we've picked up as we've gone?
So we work as part of an LMNS, a local maternity system that, and our partner in this is NWAFT, but we're also part of a wider region. NWAFT. Yes. So Peterborough and Hinchinbrook. And we work very closely with them and do visits to each other's sites. The DOMs work sorry, I keep using acronyms, apologies for that. The directors of midwifery are in communication and are part of a specific group for the East of England that will discuss issues and problems. We also will look at different hospitals that have good outcomes where we may be struggling. So, for instance, if we go back a year and a half, we looked to go to other hospitals such as Birmingham with around our postpartum hemorrhage rates. We are now in a position where our postpartum hemorrhage rates are very good, and other trusts are coming to us to say, how have you changed things and how have we improved things? So the way that impacts and that learning is shared, I would say the majority of it is shared at a senior leadership level, because it is about implementation of process and how do we change the way we are doing things. And then from that process change, we would then do education within our own system, within our own hospital, through the different methods that are informal, weekly, things like, as I said, the Rosie report or the huddles, but also that mandatory training that we do. So again, going back to the postpartum hemorrhage, we've introduced a new acronym, a new way of training on that, which we are making sure that the whole team knows. And then any new entrants to the Rosie, so any new employees, that they go through that within their mandatory training and their induction period.
We've got about 10 minutes left, so can I put in the final round of questions and then pick up as many as you can in the time? Yes, you're welcome to. With the microphone.
That was and so the learning, and you're giving very good examples of that. was that mandatory from the CQC? Did the CQC tell you you had to go to the group of 10 and to North West Anglia, or was that your choice?
Okay, do you mind making a note of that? And I'm going to put in the further questions. I've held back myself. These are my questions. We've addressed it a bit today as if there's a unique problem at the Rosie, whereas all of us know there have been problems about safety in maternity units nationally. And I want you to comment about the national position and where you sit within that, but what you think about the national position, because I think we might be falsely giving the impression there's only a local problem when many of the issues we're talking about are definitely being experienced elsewhere. Secondly, I think perhaps you did misunderstand my earlier question about midwifery training. There's an issue about how we get more numbers into training if you're going to be able to recruit them. And so I would be grateful if you could revisit that question. Thirdly, to Camwell, we began a very interesting conversation about attitudes to the National Health Service to women's health as against men's health, and still the attempt to address some old issues that are there. And I'd like other members of the committee to hear your thoughts about that. And finally, and I think it's a good one to finish on, inevitably, we've been talking about a lot of detailed issues this afternoon, but your aim and our aim must be combined, is that we want to give confidence to women and to families that they're going to get a good experience. So in lay terms, that ordinary people can understand, what is the message you want to give to mothers and expectant mothers about the confidence they should have in your service? Please.
Great, thank you. So I'll pick up the complaints question that we didn't pick up in the last round. Then on learnings, should we do a double act on that? If that's okay, Canwell. Would you be able
You've
to
got
answer
less
the
than 10 minutes though, Roland.
Okay,
so
no,
it has
well,
to be concise.
Well, we're going to be brief. Okay, I'll start on complaints, and then do you want to pick up on learnings, and then how we get more midwives into training. I'll talk about maternity nationally. You'll talk about challenges in establishing women's health hubs, and then I'll pick up on in lay terms what does all this mean. Okay, so just on complaints very briefly. So there are multiple routes where patients can say what they think about the service, and you're absolutely right. The friends and family test is only one of those, and people can give positive and constructive, negative feedback through a range of routes. There is PALS, there's letters, there's conversations with staff. Patient groups are enormously important for particular services. So the chairman, Mike, and I will be meeting with members of the public on Monday, and they've sent a series of questions through to us. Also, the Council of Governors is a very effective mechanism for patients to say we're really not happy about the care that we're receiving or some part of the functioning of the hospital. So there's multiple routes in, and then we're able to deal with those complaints. I think the additional piece for us, though, is how you triangulate what you're hearing from patients with what you're hearing from staff. And for that, we use the staff survey, adverse incident reporting, freedom to speak up comments, and then particular groups of staff have their own surveys. And that gives us an ability to say, we think we've got an issue of some sort in this particular service. What can we do to get it better? It can be quite unusual to have a sort of huge spike in either staff or patients. There's normally a correlation between them. And that's where we're able to identify the areas that we're concerned about. Do you want to move on, Canwell, to talk about some of the learnings, whether they're mandated or not, but how we reach out?
Sorry, the question was around the CQC mandate that we go to other trusts. No, it wasn't that directive, and it's something that when we have an issue, we benchmark against other areas, and if we identify someone that's doing something well, we will go there. But in addition, we do take a lot of advice from our regional maternity team and our ICS, and they had some very good suggestions about who else we could approach for advice, because they see those teams in action as well. So that dialogue continues, and it helps to guide us to look to other providers. We are interested in learning from other providers because they can be doing it very well, and sometimes they will come up with suggestions that we will not have thought of.
Thanks, Canwan. And if you want to maybe think about the question on how we're going to attract more people into training, and I'll just comment very briefly on the national perspective on maternity services. So there are quite a large number of reviews going on into health and care at the moment. I mentioned the Darcy diagnostic published 4 or 5 weeks ago, Penny Dash's review into the Care Quality Commission, and obviously Donna Ockenden's review into maternity services nationally, which I think recognised real strengths and areas where people could be positive about maternity services, but also some quite profound challenges that the services are facing. It wouldn't really be appropriate for me to comment at length on Donna Ockenden's findings, other than to say I think a lot of us recognise what she set out. Do you want to talk about moving people into training, how we can support them?
I think this was secondary to a conversation we had about why do we struggle to recruit in the East of England in terms of maternity, so midwifery and medical. And the consideration amount medical training is, we know that people will either train and go back to the region from which they originally came, or they will stay in the region where they did their medical training. And we have our medical schools here, but secondary to that, particularly for obstetrics, and across a lot of specialties, actually, it is known, it's been established that the East of England has a fewer number of trainees for its population than compared to, say, London, for instance. So London has always been overly subscribed with trainees who then remain there. So some of the push is around how do we actually get some of those training numbers out into the region. Those are conversations we have with the deanery. The other issue we've had nationally is the number of trainees within obstetrics and gynecology has not increased in relation to the population increases as well, and the changes in acuity. So that is where some lobbying has to take place at Royal College level, but also potentially at governmental level, because that's where the funding comes from and the allocation of these posts as well.
Thanks. Do you want to come on to establishing women's, which I can read over your shoulder, but not everybody can. Go for it, Carol.
So we had another conversation around how much do we prioritize women's health, say, compared to men's health, such as prostate screening, etc. If we have a look at a couple of years back, 25 million was ring-fenced and earmarked for women's health hubs to provide services such as contraception, around menopause periods, that type of care. There has been a recent study which has shown that these have not all been implemented, and that in some places they have gone ahead, but actually for the East of England, and I've checked this again recently, the conversations haven't really started and they haven't moved forward. This isn't something that sits at trust level, it sits at ICS level, and it's something we need to consider about how do we push or try and gain some traction on that, because it will take the care back out into the community, which is important when we consider models of care and resources. They should be looking to early next year for their implementation, but I think for the region we may be behind on those currently.
Thank you, Ken. Well, then in response to the last question, so clearly we would much rather have had a service that was rated good by the Care Quality Commission, and it's not for the Care Quality Commission badge, it's because that's the service we should be providing to our patients, and it's what our staff expect, it's what all of you expect as elected representatives. I think my sort of 3 points would be, first of all, we've welcomed the scrutiny and the oversight and the opportunity for joint learning. And in particular, the visit last week, I think, was a terrific model for getting to a really good one version of the truth as to what's going on. And this was something we knew about before. This wasn't a surprise, but I think it's shown up that we need to move faster and do better for our population. So that'd be the first point. I think the second point, to situate it for our patients, is this is not of the scale that we were talking about in 2015-16, or we're seeing in some of the very concerning reviews of maternity units elsewhere in the country. I think this is quite narrowly focused on a number of issues, and it's important just to be honest about that, not to be complacent, but to be direct and clear about where the issues sit. And then the third point, I would hope that we've demonstrated today that we're taking the position very seriously and acting on those two major areas of staffing, and Canwell, some really fantastic answers, and then in particular on culture and how the team works well together for our patients and with our patients. But thank you very much for the opportunity to come today.
And as I'm required to do, I'm going to make a few summing up conclusions, but then Rashenda combines that with the recording and we come up with the formal conclusions from today. But I think we should certainly recognise that there is a higher level of complexity in your work, acuity in your terms, and that the efforts that you've made to improve staffing levels are bearing fruit and indeed likely to reach targets. I think we should acknowledge the efforts you're making to ensure that there is safety across your service. And for example, we should welcome the fact that you now have higher than average performance in terms of postpartum hemorrhage rates, and we should congratulate you on that. I think we're pressing you on safeguarding training and we want you to have a higher an aim at 100% safeguarding training. I think we should encourage your continuing efforts in relation to the culture of team working, recognising that your staff do report to you that they feel they're working under pressure. We've pressed you on the timely and open transmission of data, but also would want to recognise that you're trying to reduce the burden on your own staff in terms of getting the balance right between data monitoring and staff providing their service. On triage, you've shown that you've really addressed hard that issue, but you have said that 20% of women who are due to be seen in quarter of an hour are seen after an hour. And so we encourage you to continue in those efforts. I think we should welcome the fact that you are undertaking your training programs, but pick up that last point about there needing to be higher levels of numbers going into gynecology and obstetrics in the region and nationally. I think we should recognise that we have mutual objectives in terms of workforce quality and retention on issues around affordable housing, transport to schools, cost of living supplements, that adult social care experiences certainly as much as yourselves, and that we should join together in learning and trying to address those issues. I think we should welcome your efforts to increase access to interpretation. We should highlight that issues around satisfaction levels don't always accord with your results in terms of medical outcomes. Encourage you to have further efforts in relation to satisfaction levels. And in relation to that, you've committed to give us some more information in that respect, and recognise that some of those issues around postnatal care. We welcome what you said about the recognition of new models of care and not just taking decisions about increasing number of beds, but taking any decisions in that context. And I think we would support you in that, and also want to recognise what you've said about protected beds within the maternity services arena. I think we should welcome the action you take in relation to Red Fair events and recognise that you've had a extended period free from those. I think we should note the Donna Ockenden report on maternity services and recognise that your efforts and any recommendations that we make should be viewed also in the context of national challenges to the services for which you're responsible. And I think we should, and it's very good that Louis is in the room here, that in our region and in our ICS, the progress towards implementing women health hubs is stalled and should be revisited in terms of there to be a equitable approach in terms of treatment of women's vis-a-vis men's health. I apologise for omissions in that process, both to the members and to our guests, but it does attempt to provide something that I think will be helpful as we draw our conclusions together. We've had a very full session. I concur with Roland and Camille that the quality of our discussions last week was great and has definitely contributed to it. It's felt a bit rushed sometimes today. So I hope that hasn't been how it's felt to everyone, but I think it has shown we're dealing with really serious issues, and I commend you for the candidness and openness with which you've been answering our questions. Thank you very much indeed.
Thank you for having us. Thank you.
And without hesitation, I'm going to ask the two further guests, as soon as there is a vacancy, to join us at the table. And that's Louis Campher and Deborah Lee. And we're going to go on without a break. Caroline, you're welcome to stay at the table if you choose, entirely up to you. The second item this afternoon is the redevelopment of Hinchinbrook Hospital. We're pleased to welcome Deborah Lee, Senior Responsible Officer for the redevelopment programme, and someone again who we meet with and work closely with, Louis Campher, the Deputy Chief Executive of the Cambridgeshire and Peterborough Integrated Care Board, who's always welcome in this room. Caroline Tyrrell-Jones from Health Watch is going to stay with us. And again, if you indicate, are welcome to contribute. You've kindly provided us with a report on the Hinchinbrook redevelopment and a very helpful slide pack, which has been already distributed to members with your report. I'm not sure if are we using the slides today, Mishenda?
If we are planning to use the slides, it'd be helpful to know, because we're going to need to get that set up now. It does take a couple of minutes.
I mean, if members already have it, we're happy just to talk through that.
I think that may be better for time reasons,
Yes.
to do that. So let's just agree that, although I do see Councillor Sutter. No, she's happy. That's great. So what I would like to do is to ask Deborah to introduce briefly the report, and then we'll have members' questions.
Thank you, Chair. Recognising that the value of this session will probably come from your questions and our answers to those questions, I'll keep this presentation relatively brief. You'll see from the first slide there that we have a really compelling case for change. We are one of the hospitals affected by what's known as RAC, so otherwise sometimes called concrete cancer, but nevertheless, as you can tell from that rather unhelpful term, is something that is causing us concerns. This is the highest risk in our trust risk register, and this reflects our approach to addressing that. 75% of the buildings are affected by RAC. We have had an extensive programme of inspections and fail-safings to ensure that although the buildings are beyond their intended life, they remain safe for patients and for staff. Very positively, we were included in the government's new hospitals programme, and you will be aware that that has been called in for review by the incoming government. However, positively, the RAC schemes are not part of that review, and we have had confirmation in writing that our scheme will be going ahead, which of course is incredibly positive. The next few slides just try to give you a sense of the site itself. You'll see this is a complex programme. We have to build a new hospital whilst continuing to deliver all the services that we do. We've got some complex enabling works to enable us to do that, including some demolitions, changes to road access and the like. We're just in the midst of discussing our pre-planning applications with Huntingdonshire District Council, and your own council officers have been very helpful in engaging in those meetings in respect to things for which you're responsible. There will be two important retained buildings as part of this site. If anyone's familiar with the site, you may know that we have a treatment centre that was built more recently. and that's a really fantastic building still. So we'll be retaining that building. That's a complexity because we need to wrap the new hospital around it. And we've also spent the last couple of years building 7 new theatres. We are expected to take those theatres on probably this side or just after Christmas. So that's again been a lengthy project. To your questions around how do we ensure safety, very positively, that project has given us lots of opportunity to test and iterate the way we do building works in a rack building whilst continuing to deliver services. So whilst I wouldn't have wanted to be in this position, actually that's a small silver lining that we've been able to test many of our operational procedures through that slightly smaller, well, considerably smaller building project. Going on to just touch on again, to address one of your questions about the vision. When my colleagues, predecessors were here last time, we talked about our wider vision for the campus. The strategic outline case, which has just been approved by the Trust Board and colleagues in the ICB, that doesn't include the full campus vision. That wasn't part of the funding envelope. The funding is there to re-provide the new hospital, but our vision for that extended campus very much is at the fore of what we're aiming to do. It doesn't bring money with it. We'll need to work with partners locally, with other individuals that may want to invest in our campus. I think there is huge opportunities, particularly Huntingdonshire, in terms of the things we could do with that campus. So we're talking about skills and learning, talking about key worker housing, things that have an affiliation with health and social care, but aren't directly about hospital re-provision. Going on just to touch on the future models of care. Again, I won't labour the points here because they're there for you to see, but you'll see our vision there, and a really important part of this vision is to think about how we deliver care differently. We've got a phenomenal opportunity to maximise the digital contribution of healthcare, both in terms of support to patients with their health, but also in the hospital per se. So this is referred to as a smart hospital, which means that we'll be optimising every digital innovation that is available to us as part of the hospital programme. And there's a considerable sum of money as part of the overall envelope of the hospital that we are required to invest in digital capability. And some of that really is leading edge and very exciting, and not only advance the safety of care, but can also advance the quality of care. I touched there, but more fully in the written paper, on the way in which we have sought to engage with a whole range of stakeholders. Our staff are obviously central to our planning and thinking about this, but no less so than our patients, our local communities. We're in the early stages of engagement, and I'd certainly welcome hearing today other ways in which we can involve you, local residents, in the next steps. We've had a session with Healthwatch. We've got more to come, and I recognise from my previous careers and experience that we don't need to reinvent the wheel. There are lots of community organisations working with patients, working with those that perhaps don't find access to healthcare as easy as somebody like myself may do. So wanting to reach out to those networks through the established links rather than expecting people to come to the hospital or join a Zoom meeting to engage with us. We recognise we have to go out and engage with our communities. I'm going to just invite Louis to conclude with a few comments about the model of care before I wrap up with just some of the timelines that we're working to. So Louis, do you want to just touch on the out-of-hospital care models?
Yes, so I think it's safe to say that with our population changing the way that it is, and we've had lots of conversations in this room about what's going to happen in the next sort of 10 to 15 years, and a lot of the modelling that we did to support the hospital certainly indicates that the demand pressures that we will see as a health and care system, you know, in the time to 2040, 41 is going to be very, very significant. And we have been doing kind of a lot of work to try and work out what the kind of the key interventions are that we could make in order to live within essentially what would be our kind of new hospital in Hinchinbrook. But actually, we've got the same problem across the whole ICS in terms of our kind of other hospitals as well. And that's a problem that I think that the rest of the country is facing as well. So significant modelling work between us and the trust and colleagues in this room in terms of what's coming, and we are much clearer now in terms of a blueprint. You know, we call it the new model of care or healthcare utilization, but actually some fundamental interventions that we can make in order to, you know, shift care out of hospital, much more preventative, much more upstream. In the next sort of 5 to 10 years, we would need to see a very significant shift in order for, I think, both health and care to be sustainable. And the work that we're doing as part of the new hospital program, and I think we'll come back to this conversation a number of times today, it's not about the in-hospital, it's about how the whole system works together in terms of making that capacity work. Because a hospital bed is one area in our kind of system, but actually that's just an example of where we would face pressures. We would have that pressures across our system, and that's why I think the interventions that we're now talking about, the left shift as we call it, is so vital. And I heard Roland kind of earlier talking about the Darcy review. That's very much spelled out in the Darcy review as well, and I'm sure when we start looking at the 10-year plan, that will be a key part of it as well.
Thank you. Before I come on to the timeline, I guess just a quick reflection on those comments.
Your microphone, please.
So I'm not usually accused of being quiet, so apologies for that. But yeah, just to bring to life, I guess, for a moment, that observation of Louis around different ways of working. So today we have 20 patients being cared for in what we describe as our virtual ward. So they're being cared for in their own homes, in their own beds, with support both from digital technologies, but staff who are supporting them at home. 6 months ago, they would have been in an acute hospital bed. And I'm sure you've heard before the challenges that represents to people, particularly older, frailer people in terms of a loss of independence. It's not a great word, but deconditioning. You know, within hours of being in a hospital bed, you start to lose independence, muscle mass, etc. So they're the sorts of things that we are working together on. And although the new hospital is 6 years away, that's just an example of how we're trying to be very front-footed with this, so that we understand before we get here that we're able to manage the demand in the future in, as Louis said, a sustainable way. And then finally, just to come on to the timelines, as I said, we've just had very positive approvals by both statutory organisations for the strategic outline case. That now spends 4 months wending its way through government before it's finally signed off by the Treasury. We then proceed to the outline business case, which we will hope to sign off in the summer of 2026, and then the full business case in 2027. And after that, hopefully, without any difficulties, we'll commence construction. The government's expectation is that we'll exit RAC hospitals no later than December 2030. That's a very tight timeline for us, a very tight timeline. We have a programme plan that does achieve that, but there are a number of variables in there that feel quite unknown. So, for example, until we have appointed our contractor, we can't be definite about the construction period. So we've got a milestone, we've got something that's probably better than a guess, but isn't necessarily what we'll end up with. So although we have a plan that gets us to 2030, there is a fair amount of risk in that plan. So I just wanted to, yes, be clear on that point as well. Thank you.
Thank you. There's 2 rounds, maybe more, but 2 rounds. The first on safety issues, and I'm going to ask, I believe it's Councillor Slatter in a moment to be the first speaker. And then we've got a second round on format, and Councillors Seif, Teflin and Horgan will be in that round. If there's time, I will ask other members also to come in. On safety, though, I invite Councillor Slatter to come first, please.
Sorry, Chair, I'm not sure how that happened, but I wasn't planning to ask a question about safety. If I can ask a question, something else later.
There's lots of questions, and thank you for making time for other people that do want to. But I'm going to put a question on behalf of Councillor van der Ven, who apologises she's not here, but she's interested, Deborah, that you give us. Do you mind if I call you by your first name? No.
Please.
Sorry, I didn't hear. The question from Councillor van der Ven is to ask you just to give us more information about how service delivery will continue during the works and the interim arrangements you're putting in place. I know it's in the report, but could you just give us a bit more colour on that, please?
Yes, of course. One of the benefits of the Hinchinbrook site is it's quite extensive, it's quite large. And so we are able to build the hospital in the southern corner of the site without encroaching upon the main hospital. So although there are some enabling works that enable us to achieve that, all the services that we currently provide, we will continue to provide throughout the full duration of the building work. So there'll be no impact on services. There will be potentially some impacts in other ways. So, for example, as you might imagine, we may lose some parking provision. However, we're seeking to remedy that. So we will be supporting staff to park off-site and use park and ride, so that the number of parking spaces for patients isn't reduced during the building works.
Thank you. Let's move on to the other questions. Councillor Seif is first.
Thank you very much. In a way, your presentation has preempted one of the questions that I was going to ask, although I think you may have had notice of that question anyway. But it's, and we could discuss this all day long, actually. That's the problem, the vision thing. I don't think there's anybody here who would demur from the vision that you have for this hospital, and we would support you. It's very ambitious and it's absolutely right. First thing is obviously to re-provision what you do now and then develop on. But my first reading of the presentation you gave us was that you're going to be pretty well all things to all men. You're going to, obviously, the very specialist services would be possibly provided by Edinburgh or Peterborough if you couldn't handle them, but certainly on the digital, as you said, state of the art. But you have yet to get approval to the outline business case. And then it's going to be a detailed business case. And then you've got to find a contractor, as you absolutely said. And this is not meant to be a negative question at all. But what I'm going to ask, what you think you would take out first if you had to reduce the scope? Because in the construction industry at the moment is a complete mess. Prices are going up. It's very, very difficult. Even if today you had to estimate the costs of a new hospital, it would be difficult. People will give you a design and build price, but then they won't keep to it for a variety of reasons, if they'll actually offer you that at the moment. Now you're talking 3 years' time. Is there a plan B? I don't want you to be forced to think about that, but it seems to me you're trying to do everything. And there is another little problem, which is not all the hospitals that you may be relying on for support services, like the cancer hospital, it's under review. I mean, it's unthinkable, really, that it would be not given the go-ahead, but it might be. And that puts more pressure on a local hospital or local general like yours. So, pretty wide-ranging question, as I say, we probably talk about it.
I'm going to take 2 more in this round, if I may, Deborah.
Okay, thank you.
I did say to Councillor Seif when we planned it, I thought that was the most difficult question you'd
Yes,
asked today.
and I'm going to concur with you, Chair.
But no, I am going to take 2 other questioners, so please make a note of your answers and be ready to answer them together. Just to alert you, Councillor Horgan's next, but then it'll be Councillor Tevlin online. Okay, so if you're ready, Councillor Tevlin, but first, Councillor Horgan.
Actually, I think my questions may have already been answered.
In which case, that's fine. Let's move on. I want to get as many as possible.
So I'll,
yeah, if you want to come back later, wave at me, but that's great. Councillor Tevlin.
And yes, I have a question around the impact the development will have on Hinchingbrook Road and ambulances and emergency services getting to and through whilst this is all underway, and including it's not too far from the police station as well. So what's sort of been put in place for that in terms of the safety mitigation and patient safety? Thank you.
Thank you. Seen and heard very well in the room, Claire. Councillor Daunton.
Really, it's in relation to what Councillor Seif was just saying. Thank you very much for sending the slides. I mean, really clear and helpful. And you've got a statement, the Hinchingbrook Hospital redevelopment is a once in a lifetime opportunity. It's a very optimistic statement. I'd like to ask what plans you have for involving patients, users in the design of the hospital, and particularly in the design of accident and emergency, the first experience of a hospital when a patient is in distress.
I'll close at that point, but there will be another round, folks. Deborah.
Thank you. Would it be cheeky to go in reverse order? Because I've got them in my mind that way. I will get to them all, however. So on that final point, I absolutely recognise the importance of involving patients in that design phase. I've built a number of hospitals in my time, and I think I can walk in people's shoes, but actually you never can until you're there, perhaps, you know, an anxious mum with a young baby or whatever. So I'm absolutely recognise the value of that input as early as possible. The next phase with our architect is what's called REBA Stage 2, and that's when we move beyond concepts into design. And we have a raft of ways in which we will involve not just patients that are in our care now, but looking ahead, particularly to younger people who will be using this hospital for a number of decades to come and will have different expectations, will have different relationships with technology. So working partly with our Council of Governors, but more importantly with communities to really ensure that we get that right. And again, if you've got any thoughts, suggestions, examples of good practice, really keen to hear that. Not today, I appreciate that, but I hope this is, as Louis said, the kind of start of a conversation about this. On to the second point about ambulances and traffic congestion and the impact per se. There'll be a number of temporary road provisions to enable this to happen. So egress and exit from the site in ways that we don't have now. We'll protect the blue light route. So that won't be, for example, be able to be used by contractor or construction traffic. So we've done a whole series of traffic modelling scenarios to just understand that impact. Again, understandably, local residents are concerned. If you've tried to leave Hinchinbrook at 3:30 in the afternoon when the school's trying to leave, you'll know that it gets pretty congested. So one of the things I'm really determined to address as part of the new hospital is to completely rethink the way that traffic comes in and out and moves around the site. But for a period of time, it will be a challenge, but a challenge that I think we can overcome, particularly in respect to maintaining that blue light route in and out of the hospital. And finally, to the $64,000 question. So firstly, for a moment, let me just kind of explore the risks. So we understand a fair bit about the cost of hospital now. The programme business case that's going through Treasury recognises that the costs, no good modelling on what it costs now, so they have projected forward using construction inflation and recognising things happen in the world. So when we were building the theatres, Ukraine was upon us, and that increased the cost of the supply chain. And so provision is made for that. We've got a myriad of contingencies in the sum that's being approved. But in a scenario where we've used all of that up and we're still struggling to get a business case to stack up, that will be a conversation for us as a system. So, for example, we have more beds in the hospital than we have now. The rooms are much larger. So, and that's to build them to good standards. But a conversation we would have as a system with the department, with the new hospital programme, is to preserve the number of beds. Do we want to make them slightly smaller? Because this is single rooms. Now, they'd still be twice the size of what we've got now, but maybe not 3 times the size of what we've got now. So what I want to do is to hang on to the vision and the services that we've got. I don't want to lose services from Hinchinbrook or from the local area. And so we'll just have to cut our cloth accordingly. I regret saying this, I'm pretty confident that we can achieve this, provided the funding we hope is available is available. And as you alluded to, the programme business case has not yet been signed off by the new government. So until it's signed off, we can't be certain about that point.
Shall I pick
Yes,
up
please do.
So just on the Children's Hospital, Cancer Hospital, the other developments that we are planning at the moment, the current working assumption is that, of course, we want our population across Cambridge and Peterborough to benefit from those very specialist centres, and it's great that we will have them. I don't think it impacts materially at the moment on the flows, because actually what we did, the flows that we were seeing at Hinchinbrook is a very different patient cohort than will go to those very specialist centres. So you're absolutely supporting them from a kind of ICB perspective, but that is probably less of a risk for us at the moment in terms of the Hinchinbrook redevelopment, if that answers the question. I do think as I said earlier, our prediction forward is that there will be, across the ICS, significant shortfall in kind of hospital beds and other capacity, kind of services. And I think that is why collectively we need to pool together and make sure we do the right things in order to prevent as much as we can so that we can be much more sustainable.
Thank you. That
Just-
answer
Just
about.
reply by wishing you luck. So we really
Thank you,
are
Jeff.
behind
Thank you, Jeff. We've got the next round coming. That answer about the making the room smaller and smaller. It's going to end up like a Barrett home house if you're not careful. Be careful. Last round, Councillor Goodliff.
Thank you. Looking at the pictures, it says that residential accommodation is going to be demolished to facilitate development. Assuming that's residential accommodation for staff, what are the implications and risks around retention and recruitment without that being there?
Thank you. That's a really great question. I spent-
Sorry, can you take them together again, please? So I'm
Oh.
trying to get everyone in. Councillor Slatter is coming in now.
No, I'd rather wait to hear to that because mine overlaps. I think it may be answered.
There
or
may
is
not be another
contained.
chance. There may, Councillor Nessinger.
So I hope mine won't take too long. I think it's very fortunate on the Hinchinbrook site that you've got the space to build the new hospital while the current one is still running. In order to make the capacity of the new hospital manageable, there are going to need to be ways in which we change the way we deliver care. And some of that is probably going to be about looking at different kinds of accommodation for people outside hospital. Are you thinking about that in terms of the space that will eventually be freed up on the Hinchinbrook site after you've built the new hospital?
And last one from me, which is aimed at Louis, really. We meet together regularly. I know that you do work very, very hard on the new model of care, and that we're not just providing hospital beds, but you're coming up with alternatives. But I think it's fair to say in this meeting, the public won't know that that's going on at all. And the words we all use, including us, around that, the public won't identify with. And so I think in a very practical layperson way, tell us how you're not building more beds at Hinchinbrook and what you're going to do as you're not building those more beds. So we can put this in that context, not the theory of it and the model, but in very practical terms to give the public confidence that collectively we all know what we're talking about on this. Please, both of you, of course.
I'll lead off with the accommodation question, then invite Louis to comment on the second part. So I've spent today meeting with staff who will be impacted by this. The accommodation needs to be vacated by autumn next year, so we can clear the ground in preparation for demolition in January 2026. We will be providing temporary accommodation for the period of time. So there'll be no period when we don't have accommodation. We won't have as much accommodation because we're very fortunate in the amount of accommodation we've got. So for that interim, we'll have a reduced volume of accommodation. But hopefully by the time we're out to 2030, we'll have re-provided more again. So for the period in between, we've got a really clear policy around who's eligible for accommodation, and we'll have sufficient to ensure everyone that is eligible can access accommodation. The eligibility criteria enables them to access it for 3 months. So this is typically for new starters, so perhaps overseas colleagues, nurses, doctors that join the organisation. We give them 3 months to settle and find their own accommodation. Staff that are on call can access that accommodation. So there's no permanent loss of provision, but for a period of time it is reduced. And I think we can manage that impact.
So to come back to the question around kind of, I suppose, out of hospital accommodation, I think if I answer a little bit about the question on sort of different care models and then come back to that question, that may be helpful, because I think we are in a world now where I think we should recognize that a state isn't always our first option to provide good care. And more accommodation isn't always actually the right thing to do, coming back to some of the points that Deborah made earlier. So if I just try and bring to life a little bit some of the opportunities that I think we've got, because I think there's so much negativity sometimes around kind of demand pressures, etc. So if I highlight 2 kind of areas in what we call the new care model, the first bit is around kind of health optimization. So we now have the ability to really understand how kind of patient risk at a very individual level. And we have the ability to actually work with patients really proactively to mitigate any part of that modifiable or reversible risk that they may have in a way that I think we just couldn't do previously. We've had lots of campaigns that, may have tried to, persuade people to do something different, but actually it fell on the masses in a way that actually wasn't individualized, and patients didn't really understand that that was a risk that was very specific to them as an individual. And working very closely actually with Val and public health, we are doing a proof of concept at the moment where we are specifically focusing on cardiovascular disease prevention and using that sort of approach by going after very individual risk profiles for patients to try and reverse it and work with them to reverse it. And we're running a proof of concept at the moment that's kind of a few weeks running. We'll talk a little bit about that tomorrow at the Health and Wellbeing Board development session, but actually it is starting to show that it's possible to do that, and that will have a significant impact on the pressures that we will see further down, because the more strokes and heart attacks we're able to prevent, the more we can push those adverse events back to a later age in life, or as our clinical elites will say, over 75. It will make a fundamental difference to the kind of the profile that we will see. So that's an example of actually how you could really bring that to life. And the reason why I keep kind of talking about it is we need to do that now, because when Hinchinbrook opens its doors in 2030, we won't have enough beds. By 2040, we could build another 2 Hinchinbrook hospitals, and it won't be enough. That's the reality of our aging demographic. And I used to be in a finance role, and this role, in terms of kind of the data and that side of things is a bit new to me. And I know people talked about the aging population a lot. Until you really understand what it means for us in the next 5 years and then the 5 and 10 years beyond, it is absolutely stark. And so we need to, in the next 5 years, radically shift our models of care in such a way that we are able to say by 2030, we are seeing a different demand profile going into our hospitals. Otherwise, I think, and again, I'll reiterate, I'm using hospitals because we're talking about Hinchinbrook, but it isn't just hospitals. It's our kind of wider health and care sector as well. Another example, just from the kind of care model, is we know that for a population that's reaching the end of their life, we are not necessarily doing what we can, and we're not always allowing isn't the right word. People don't always die in their preferred place of death. About 30% of our hospital beds are occupied by people in the last few months of life. And that's a very, very significant number. And for a big proportion of those patients, actually, they don't necessarily have to be there, and they don't want to be there. I completely understand that in some cases it's inevitable. And so again, with the technology that we've got now with remote monitoring, with some of the things that we could in place for people around their home or their preferred place of death, actually we could do fundamentally better there. And so there's a number of areas that actually, if we really go for that as a system, we could fundamentally change the profile. And it is so important that we do that, because Hinchinbrook will not be big enough, nor will Addenbrooke's, nor will Peterborough City Hospital. And to come back to my point then around actually that is the lens that we should apply to any other estate that we may need, because we will need estate, and we will need, community hubs and health hubs and better places to do diagnostics. But I think we should do that through the lens of what's possible to do now with kind of out of state, closer to people's homes, in a way that you are actually enabling them to interact with healthcare in a different way before we think estate. Because if I can just say this, our health inequalities in our system is driven by things like cardiovascular disease in a very significant way. The reason for that is people step away from their care because we offer it in a way that doesn't always suit them. We now have the ability with remote monitoring to say to someone, look, I understand you work a shift. We can send your blood pressure monitor machine to your house. We can get your blood pressure checked. We could do things really, really differently. And I think that's what we should try and maximize over the next 5 years. And that's what the new care model is all about. Hopefully that puts a bit of context around it.
I will just give Councillor Sasser in case you wanted to come back, because you did hold back earlier.
Did, and in fact part of my question was partly seeing that indeed you are demolishing staff accommodation. I understand that the same thing is happening in Addenbrooke's. People don't want more than very temporary tied flats, do they, on the whole? But you did put in your vision housing. So I would be interested to know just how you will be making a contribution to presumably affordable housing that will enable you to retain staff rather than just look after them when they've just arrived.
I'm happy to talk to that one. So I've had meetings in the last month with registered providers, with housing associations, with members of Huntingdonshire District Council to talk about that very point. The models that are evolving up and down the country don't typically involve a contribution from the NHS in terms of capital or revenue, but we might be able to facilitate that development, for example, through the transfer of land. So as you've recognised, we'll have surplus land, that land will have a value. And so we recognise that we've just been working with an external organisation, and we've done something that we've called the Housing Needs Assessment, and it demonstrates that 45% of NHS staff working in this part of the world feel that housing is their biggest concern. And if they could access affordable housing, they'll be much likely to be drawn to an area, stay and build their lives there. So we're working on that. We have got some key worker housing on Alconbury Weald as we sit here already, only about 90 units. So very much part of the vision, but not something that we have capital or revenue to contribute to. But as I've said, we have got opportunities to stimulate others consider investing in our vision. And that's not just local authority, that's not just public sector investment. I think there's opportunities for third party and not-for-profit and even private investment.
I'm afraid we've run out of time, Councillor Satter. I do apologise. Just 30 seconds.
Will you be able to, but this would be a contribution of land, affordable housing built there, but not necessarily available for your staff into the future.
It would be framed as key work. It would be framed as key worker housing, so it would be available for a number of individuals. Just to clarify, this is a vision. We need to talk to a whole raft of stakeholders about what are the priorities for the land. Although it's a large site, the surplus land isn't huge. So we need to think about what additional campus service will add the most value to our community and our vision. Now, that may not be key worker housing. There might be some brownfield land that's cheaper, that's more accessible. People tend not to want to live where they work, actually. So, you know, there's a site in the centre of Huntingdon that we're talking to a developer about now. So, yes, so I hope I haven't left the impression that we will be having housing on there. It's one of a number of options that we're considering. I personally think we could better meet the housing need off the hospital site.
Thank you. Again, I will informally summarise what I've heard to assist the process of getting this written up. I think we should welcome the fact that there is financial go-ahead from the government because of the RAC status of Hinchinbrook Hospital. I think we should recognise the proposals for a smart hospital and encourage the development to be at the leading edge of digitisation. I think we should encourage continued engagement with stakeholders and local residents, welcome the efforts in particular made with young people, and ask the development to intensify its communications with hard-to-reach groups. I think we've said that we want greater awareness about how this is developed in the new model of care approach. I think we've had some good examples of that this morning, but want that to be made more aware to the public so people can understand that context. I think we've heard that we would acknowledge that there was a very challenging timetable to this, but we would encourage the development to adhere to it to achieve conclusion by 2030. And as we've heard from Councillor Seif, be very open and transparent in addressing contingencies if these are necessary to be found. I think we've heard from a number of councillors about welcoming the interim measures to try and minimise disruption and ensure safety in the meanwhile, particularly the efforts that we would also encourage around staff accommodation, around the offside parking, about protecting the blue light routes and other interim measures. I think we should recognise that last point about 45% of NHS staff saying housing's their biggest problem, and whether it's on the site or elsewhere in the ICB estate, encourage efforts to identify land that can make a meaningful contribution to efforts that we should all contribute to in relation to affordable housing. Oh, sorry, one that I did overlook was I would think to encourage you in relation to your vision around the campus and to welcome that and to want more information about that as time goes on. And did I get any of that badly wrong? No, thank you very much indeed. In which case I do need to ask the committee formally, are you happy that those and associated recommendations are written up and then go to the spokes for agreement and for final agreement? Is everyone happy with that? Nods on all sides of the table. Don't quite go yet, but allowed off are both of our guests, Louis and Deborah. Thank you so much for spending time with us this afternoon. We'll see you tomorrow, Louis. Maybe not you tomorrow, Deborah. And we warmly welcome the time you spent with us and the spirit in which it's taken place. Thank you very much indeed. Just quickly, other business for members before you can go. We have the health scrutiny work plan. We do have a proposal from the officers for a second item for December. Patrick?
Yeah, thank you, Chair. We're recommending that scrutiny in the December meeting is around urgent and emergency care. This is a concern which is ongoing. Performance is lower than it needs to be. NHS England has just done its annual assessment, and their recommendations is they have similar concerns about 4-hour waits, ambulance turnarounds, etc. So we feel that scrutiny should invite colleagues from the health service, maybe the acute trust as well as the ICB, and ask them a series of questions around the kind of assurance of both improvements around their urgency and emergency care, and particularly in the winter months about their readiness and preparation for that.
Which will be very timely for December. Can I just remind colleagues that when we have our health scrutiny preparations meetings, we have a bit longer to talk about future items. And so next time we do one of those, we'll have a longer discussion. Bearing in that mind, are you happy to confirm the health scrutiny work programme and the arrangements to develop our annual plan? Are you happy to nod that today? Claire first, Councillor Daunton, sorry.
Yeah, I'm very happy about that, Chair, and really happy about the suggestion. I just, again, go back to, can we put the pre-meetings in the diary quite soon, because December's coming up, isn't it? So the date for the pre-meeting. Yeah, thanks.
Very fair request. On those two recommendations about the work programme, everyone happy? I just need to see people nod. I won't ask you to answer the question that was put to you while you were out of the room. It wasn't, I'm just kidding. It's an old joke, that one. It shows I like you. The final item of business is the health scrutiny recommendations tracker, just to show that we're keeping watching. Did you want to say something, Councillor Hay?
Yes. Bottom of page 197, and it dates back to December 2023, says a short written update is requested in 3 months' time. It's now 10 months. What's going on?
That's why we have this item, Rashenda.
Can you remind me which one? Nice. Thank you. It will have been, reminders will have been sent. I can feed that back from the committee, but regular reminders will have been sent.
One is that will be minuted. Two is, sorry, Councillor Steve, Councillor Hay does get Eagle Eye of the Day award. Sorry about that, but you're second. Is there, other than that, are the health scrutiny recommendations tracker, is the tracker agreed? Yep. Later by 5 minutes I've overrun, sorry, but that we've had a really good day again. Thank you for all of the participation. Thank you to our COPTA members. Thank you to our officers who serve us so well. I declare the meeting closed.